I think your program may say that that I'm Dr. Jacobs, as you just found out that I'm not. He's in Europe somewhere now. I heard that lovely talk just preceding this, and I have if you don't mind, I have an anecdote that I'd like to share with you. About 10 or so years ago, maybe 12 years ago, I had a program of bringing patients from Greece, where I was born, and difficult patients to Chicago and to operate on them. And this one kid came, and he was about 10 years old. By the way, I was 10 when the first open heart surgery was done. And so I'm not telling you my age, it's none of your business. But in any case, you might be able to. Anyway, this kid comes and sits down, and I'm thinking, I'm looking at a mirror because he and I look exactly alike, a few years taken in consideration. And his mother and father said, "Can we talk to you without the child here?" I said, "Okay." And they said, "Well, we brought him here. He thinks you're going to take his appendix out. He's blue as can be." And so I said, "Well, he really believes you?" And they said, "Yes." I said, "How's he doing in school?" He says, "He's first in his class." I said, "Oh, good." I said, "And you don't want me to tell him about this operation?" They said, "No, no, no." I said, "Okay." Well, I immediately connected with him. I didn't say anything, but we went through the operation. It was a tetralogy fellow, the most severe type. He needed a VSD closure and a conduit from the right ventricle to the pulmonary artery. He did swimmingly well. And so I brought him down to my office without his parents. Now, what you don't know about this is that I was taken by my mother when I was 7 years old to get my appendix taken out. I knew my appendix needed taken out, and she never told me where we were going. And I said, "Is this the hospital there, Mom?" She says, "No, we're not going there. Of course, we're walking right there." So I said, I can connect with this poor little kid in many ways. So I sit him down next to me, and this story is almost over. I said, sit him down next to me, and I said, his name was Nectarios Molaroyannis. I said, "Nectarios, sit down here." And like we were going to have a cup of coffee, and he's 8 years old or so. And I said, "How you doing?" He says, "I'm fine, thank you, Dr. Mavroudis. Thank you, fine. You like your color now?" "Yes, I do." I said, "What did I do to you, by the way, Nectarios?" He says, "I don't know. My mother said you took my appendix out." I said, "Where's your appendix?" And he points down to his right lower quadrant. And I said, "Where's your incision?" He says, "Up here." I said, "What did I do?" He says, "You fixed my heart." And I said, and it's one of those things. And I said, "What are we going to tell your mother?" He says, "Dr. Mavroudis, it's all right. Let her believe what she wants." 8 years old, already the wisdom of Job and the wisdom of Solon, the wisdom of Solomon. I'm going to talk to you a little bit today about tetralogy fellow, what's new in tetralogy fellow. Can you hear me okay? So the background here is these are old studies. There you can see they're 2000, 2003. But up until this time, when these studies were presented, the transannular patch incidence, and many of you know that tetralogy fellow has a very, very small right ventricular outflow tract. And the typical operation in the old days was to do a transannular incision to sacrifice the pulmonary valve. In fact, here is the incidence of a transannular patch from Toronto. They reported as 36%. Boston, they were doing neonatal repairs, and then 83% transannular patch, and Ann Arbor, 100% annual transannular patch, if you can consider those babies that were done in the neonatal period. And so what does this mean? It means that while the baby does fine, the pulmonary valve is gone, and that has some situations which are very important, which can cause a major source of postoperative morbidity, such as right ventricular dysfunction and arrhythmias and the like. And so the strategy recently, and we did this study that I'm about to tell you about 15 years ago, so we were sort of ahead of the curve in the in Chicago anyway, in the development of procedures to save the pulmonary valve. And so the purpose of the review was to see what we were doing and how we were doing with preserving the pulmonary valve in these patients. So we had 102 consecutive patients from 1997 to 2004. At the same time, these other studies were being presented. And we had these babies that were mean weight of 7.5 kilograms. They were not neonates for the most part. But if they were, and if they hadn't, they required a shunt, we would do that first before the operation. So we did a pulmonary valve sparing technique. I'll show you some pictures of it now, in 80% of them. And that was quite different than 36% or even 40 or 50% in other series. And so it looks like this. And this is a technique that I learned from Farouk Idris, who preceded me at Children's Memorial Hospital when I got there in 1989. And this is the incision that one would make. If you can see the dotted lines there, I don't have a pointer here, but you can see the dotted lines there. And what happens with these patients in the old days, one would see this supraannular tightness and would make an incision right across the pulmonary valve and not try to fix it. But if you take some time, or if one would take some time, that is to say a surgeon would take time, to make this Y, upside down Y incision, the valve opens up like a flower. And it's larger. And one can do a subannular incision and then many times save the valve by using this pantaloon pericardial patch. You can see that it's going in right there. This is how it looks this is an anatomic view that the patch is being placed, and this is what it looks like at the end. So the stenosis, which is panstenosis in tetralogy Fallot, meaning subvalvar, valvar, and supravalvar, this is taken care of, at least in the supravalvar area. And generally, it's enough to preserve that pulmonary valve. Now, in the operating room, when it's not preserved, now this is a very important point, especially in those patients that have a bicuspid valve, one has to do a transannular patch, but you do it in such a way to preserve the leaflets that you can see looking through that patch. And if you preserve the leaflets, maybe in the future the leaflets will grow and you can put those leaflets back together again and preserve that pulmonary valve for the future. We're talking about 10, 15, 20 years down the line. So it's important for us not just to make the incision willy-nilly resect the valve, but make the incision in such a way that we can preserve those leaflets for the future. It may not always be available, but it could be. And I'll show you some study about that. And this is what it looks like for a transannular patch. Note a couple of things here. One, that the ventricle is not made, there's not a large incision in the ventricle. It's a small incision. And the ventricular septal defect in this case was not closed through a large ventriculotomy. It was closed through a right atrium, which means that the smaller the right ventricular incision, the less chance of arrhythmias in the future and right ventricular dysfunction. So we measured these parameters to see, whether which children are going to be good candidates for this valve sparing procedure. And we found that of course, the larger the pulmonary valve, the more chances that the valve sparing procedure would be done. Notice here that the green is good color, is valve sparing. The red is a transannular patch. And notice that the z-scores are much higher, that is to say on the right side, the z-score meaning if the annulus is small. The higher the z-score, negative z-score, the more chance that that you'll require, or the patient will require a transannular patch. And here are the ones, if you stratify them by z-score, notice that on the left-hand side, it's -1 and then again -1 to -2 and -2 to -3. Those patients are generally thought of as good candidates for a valve-sparing procedure. Most people, at least up until this study, thought that anywhere between -3 and above is not a good candidate. But if you notice there at -3 and -4, we had some patients that we did save the pulmonary valve on. We also found that if the pulmonary valve, no matter how small, if it has a tricuspid appearance to it, it's more likely to be saved than one without. And these are the postoperative right ventricular to left ventricular pressure measurements or ratios. Notice there that on the left-hand side is 0.5. That is to say that if the right ventricular pressure is 50, that the left ventricular pressure is 100. These generally come down after the operation, and patients do quite well. Well, and if you look at these cases, 6 patients were converted immediately in the operating room to a transannular patch, like I talked to you about. 5 patients with a valve-sparing operation required late reoperation. So this strategy, one has to tolerate some reoperations in a certain number of patients. The good thing is that there was no mortality after the shunt procedure. There was a single death occurring after the valve-sparing reoperation at another institution. And the reoperation rate was no different in the transannular patch than in the valve-sparing patch operation. Well, the pulmonary valve-sparing approach in the repair of tetralogy FLO was successfully applied in 82%. And I think even now that's probably the highest in the literature. The reoperation rate was 6%. 70 or 85% had less than moderate pulmonary insufficiency, and the mean gradient, or the mean right ventricular pulmonary artery pressure ratio was 0.5, which is excellent in a patient with tetralogy FLO. And as importantly is that a prior shunt did not preclude a valve-sparing procedure. In fact, if one looks at a little baby that you're expected to do a transannular patch to do the operation, it might be better, although this has not been proven yet, but it might be better to do a shunt in that child and then wait for 6 months or so, and that pulmonary valve will likely grow. And if it does grow, it might be able to do this valve-sparing operation, which would prevent complications in the future. So again, the significant markers for success of a pulmonary valve-sparing operation are a tri-leaflet pulmonary valve, a pulmonary annulus score of greater than -4, and a postoperative right ventricular to left ventricular ratio of 0.7. So what was I telling you about if we are careful to preserve those pulmonary valves in such a way as just to divide the commissure so that these leaflets will stay in place and maybe grow. Here's a patient who I did recently here in Florida, where the child had she was a 22-year-old or so, had pulmonary insufficiency and needed a pulmonary valve. So I explored the area, and I was well known that some of these valves can be preserved. It had been published in the literature by one group at Stanford. And so this is an incision that I made over the right ventricular patch and removed the patch, and lo and behold, look what we have underneath. We have 2 good valve leaflets. And so I said, well, maybe we can spare this. And sure enough, we took that patch out, and there are the leaflets right there. They were competent. Put them together with a pledgeted suture that you can see right here, tied it, and then put a patch above it. And then by putting a patch above it, the blood would come back on top of the pulmonary valve, and I can see from the right ventricle whether it was competent or not. And it was competent. And so then we just closed. There it is. If you could have an imagination, that valve is competent. The blood is coming back from the lungs, and it filling up the pulmonary artery, and lo and behold, it doesn't leak. And you'd say, well, okay, if it doesn't leak, is it big enough? And the truth of the matter is that she came off the heart-lung machine with a 15-millimeter gradient, which is just fine. And so this lady now does not have a pulmonary valve that we have to replace sometime in the future, has her own valve that's functioning well. And we think that if a certain number of patients who require a transannular patch might be good candidates, if the valve is preserved well enough, might be a candidate for this operation, assuming that they were prepared well enough. Well, there's other things that are new in cardiac surgery. I just picked at 2 of them. One of them, of course, the preceding is tetralogy FLO. The other one is what's new in single ventricle palliation, the Glenn, the Fontan, and the so-called Fontan conversion. Well, the Glenn shunt has been around for a long time. Dr. Glenn from Yale used it in some patients with tetralogy FLO, interestingly enough, but he was not the first one to describe a Glenn shunt. It was actually done in Russia some years before his name got onto this. And of course, that was a time when the Cold War was going on. Why would we name anything after a Russian? And so we named it after Glenn, right? And he was a distinguished professor at Yale and so forth. So we used it for, the society and the surgeons used it for, initially for tetralogy FLO, and then we used it for different kinds of single ventricle palliation. And the expected findings after a Glenn like this is the central venous pressure is elevated because it's the pressure that's bringing the flow through to the pulmonary arteries. And the oxygen saturation is between 75 and 85. And this is what it looks like, a classic Glenn shunt. You don't have, the patient does not have to be put on bypass. You can see that a partial occluding clamp is placed on the superior vena cava. The right pulmonary artery is divided, and then an interrupted suture technique is used to anastomose the distal right pulmonary artery to the superior vena cava. Then you definitely get the blood to go to the right pulmonary artery by ligating the superior vena cava at its junction with the right atrium, as you can see on the right-hand side. Right-hand side. Now, does anyone, I'll give a quarter to anyone who knows where this is. Does anyone knows where this came from? Yes. No, it's not. Good try. Come on, one more. A quarter. And I'll have to break $1 to get it for you. This was the original Fontan operation that he published, right? The original one. And he's still alive. And every time I see him, we drink wine together. It's from his vineyard in Bordeaux. Lovely man. This is the first one. So you notice that there's a Glenn shunt here. You see it? There's a Glenn shunt on the right-hand side there. And then he had a valve in the inferior vena cava. I don't know if you can see it. And then the other valve was connecting the right atrium to the pulmonary artery. The idea was that this right atrium would work as a pumping chamber. Well, it never happened quite that way, but this is his own. And this is the bidirectional Glenn shunt that was actually brought forward to use in some patients like this by a surgeon in Los Angeles. And so that's what it looks like. This requires a cardiopulmonary bypass. This is not new. It's been around for a long time. And so as the Fontan operation matured, we had the so-called lateral tunnel. You see the Gore-Tex where it says the Gore-Tex lateral tunnel. And that gets a pathway from the inferior vena cava up through to the cardiac end of the superior vena cava into the right pulmonary artery, and this is the so-called Fontan operation. All the blood goes to the pulmonary artery by venous pressure. That can cause problems as we move forward. And this is a so-called fenestration. This fenestration was figured out about 15 or 20 years ago. And the idea was that that little hole there, that pale blue arrow is going through, that would get blue blood to the red side, but not so much to make the patient so cyanotic. So if you do all the measurements, the cardiac output is higher with this. The oxygen saturation is better. So in many cases nowadays, people still use this fenestrated Fontan, and it took the mortality for this operation way down for many reasons. And I think Jack Rychek will be able to talk a little bit about that. I don't know whether he's going to talk about it, but he's an expert in this field, clearly. Jack and I have been friends for 20 years, I think, right? Thank you. At least, he says, yeah, and he said it was a frown. And so this is an operation called the hemifontan. This operation is done at the second stage of hypoplastic left heart syndrome or other forms of single ventricle. Notice here that a patch is placed here so that this is a bidirectional Glenn in physiology. So then the idea, when you do the fenestrated Fontan, you just take that out and put a gusset, getting the inferior vena cava blood flow up into this area. This is used in a number of institutions as well. This is an X-ray of a patient who's had an atrial pulmonary Fontan about 15 or 20 years before this time. Notice the right atrium, how huge it is. You see it? That's right atrium. And to give you an idea, if you do a CT scan of a patient like this is right atrium. And notice how it's blocking the pulmonary veins coming back here. This is a problem. And many patients who have had the atrial pulmonary Fontan have this problem. And the hemodynamic lesions that are associated with that kind of a Fontan are systemic venous pathway obstructions, pulmonary venous obstruction. This is all obstruction to flow without a pump. And there's also patients that get left ventricular outflow tract obstruction and abnormal AV valves, which tend to be insufficient and the like. So the unwanted consequences of this over a long period of time, if the Fontan is not working well, that the right atrial pressure gets higher, the right atrium gets bigger, as you noticed, there's a decrease in cardiac output, patients develop ascites or fluid in the abdomen, cirrhosis of the liver, plastic bronchitis, protein-losing enteropathy, and cyanosis. Now, not everyone gets this, but these are things that we have to worry about after 20, 30, 40 years of Fontan circulation. Now, I'm going to take you through some slides that might be fun to see because this is history. This is an operation that connects the right atrium with a small area of the right ventricle here, and this is a Fontan operation. And these conduits here, if you will, they tend to get obstructed. And here's another one with a valve in it. Remember that Fontan used valves because he thought that this right atrium would function as a right ventricle. It never did that. So the point of this is that these conduits have to be taken out, and because not only are they obstructive, but they also cause arrhythmias. And this is the dissection that takes place to take out this conduit. And this is the right coronary artery. One has to be very careful when doing this dissection. And this is what the valve looks like here. The right ventricle tends to be quite small here, and that was the reason why the Fontan operation was performed. In this case, a patch is placed where this conduit was, and then this area here can be closed, and the atrial septal defect was opened, and then lo and behold, we have an extracardiac Fontan here. I hadn't shown you this yet, but this is so-called extracardiac Fontan. Why? Because this tube is extracardiac, away, not inside the heart, and then here is a bidirectional Glenn shunt. So this is a so-called extracardiac connection. Sometimes patients have the discontinuous pulmonary arteries. That's the one that Fontan did. He had discontinuous pulmonary arteries in that patient. We have to put these pulmonary arteries back together again. Once we put them back together again, then we can do this extracardiac Fontan as well. In the meantime, all these patients get arrhythmia operations as well. Sometimes a patient has a small right ventricle, a pulmonary atresia with a small right ventricle yet, and they have a Fontan, atrial pulmonary Fontan, and that right ventricle grows and grows, and the tricuspid valve can be insufficient, in which case it causes a whole lot of blood pressure to develop in the right atrium. The right atrium gets bigger and bigger and bigger, and that's a problem. So what we have done in patients like this, besides doing these cryoablation lesions to take care of the atrial reentry tachycardia, we put a patch on the right ventricular annulus here, or the tricuspid annulus, and leave a little hole in it, and this prevents blood from getting into the right ventricle at any great volume, so that this right ventricle now just can't make the volume that it had before and cause trouble. Sometimes, and these patients have been performed at the Mayo Clinic when they were doing Fontan operation. They made a great contribution to the Fontan operation. In this case, however, you have a patient here who's who has a single ventricle, but this patch, this tricuspid valve, had to be closed in order for the right ventricle to work into the systemic circulation. Now, the trouble with this is that they close it over the coronary sinus, and the coronary sinus is one of the landmarks one has to do the arrhythmia operation. So in this situation, you just can't reroute everything. You have to take the patch off of here, open the atrial septal defect, and then one can do the cryoablation lesions, as you can see here, with all the landmarks in sight that this operation requires. And of course, once this operation is done and these lesions are placed, the arrhythmias go away, and then it's a simple matter to put the patch back on here again after you've done the arrhythmia operation. In the old days, sometimes when surgeons recognize that there are two vena cavae, one on the right, one on the left, they got the patient ready for for Fontan by dividing the left superior vena cava right here. The trouble with the left superior, sometimes the left superior vena cava, it drains the coronary sinus. And sometimes the coronary sinus is occluded. And so in this case, the blood that's coming back from the heart and draining into the coronary sinus doesn't go to the coronary sinus. It goes to this area, and because it was, tied off, now the blood has no place to go. This is not good for the heart. In addition, it's not good for the pulmonary veins because this gets larger and larger and larger and can obstruct the pulmonary veins, which is not good for a Fontan circulation. So the operation here was to remove that pathway of the coronary sinus and repatriate it back here to the left and right atrium, which was done in this case. As we were doing this so-called Fontan conversion, that is to say, to take patients with Fontan operations who had arrhythmias and had other problems, as we were doing that, we found that we could do more than just a Fontan conversion. And from 1994 to 1996, we only did concomitant operations in 2 patients with pulmonary arterioplasty. However, as time went by, we were taking on more difficult cases, and if you can notice here, that between here and this time period, we were doing operations together with the arrhythmia surgery and the Fontan conversion, which involved all of these things, including AV valve repairs, unroofing coronary sinuses, and all the rest. So we were able to establish an operation that can be applied to certain patients with failing Fontans, but not all. This is give you an idea what can happen in this right atrium. This is one large clot that was in the right atrium that we removed in segments. And with a clot in the right atrium doesn't necessarily mean that you have a clotting disorder. It means that the cardiac output is quite affected and small and not enough for a sustaining circulation. We also repaired AV valves. You can see it here, the types of valves that we did to repair during this operation. These are the features of the valve repair. Most of this was taken from the adult population on how to repair valves. I actually went to Carpentier in Paris to learn how to do many of these annuloplasty techniques so I could apply it to patients like this. These are the kinds of lesions that are placed for patients with atrial arrhythmias and patients who have Fontan circulation. Notice that this is an area that requires cryoablation. So the idea about why you freeze certain parts of the heart, you make areas that have slow conduction into areas of no conduction. So just follow me here for a moment. A beat will come from here somewhere in the right atrium and come down here with a waveform and then come to this area and slow up. As it slows up, the rest of the atrium repolarizes and can set up a circus movement with atrial tachycardia. So the idea is to find all these areas that have slow conduction and freeze them to make them no conduction. So that means this waveform will go through tissue, normal tissue that is fast and not cause atrial tachycardia. And that's the whole thing behind it. These are the lesions that are placed. This is specifically for tricuspid atresia. You can't use a tricuspid annulus as a landmark because there isn't one. And so these are the lesions that we place. And sometimes there is a tricuspid annulus in single ventricle patients, then we do use it and try to convert areas of slow conduction into areas of no conduction. I think I'm losing some of you, and I'm sorry about it. I think it's rather complex stuff. I'm trying to teach my colleagues about this, and they refuse to learn. And I think, you know, they think that arrhythmia surgery is magic, you know, as if to say, well, you know, that's why I say, look, listen to me. You're converting an area of slow conduction to an area of no conduction. Can you get that? And, you know, I'm not you. I'm sure you get it. It's not, it's my colleagues. They have some kind of a break here. Now, this, when I show them this slide, then they say, yeah, I'm going home. Now, you see, these patients have congenital heart disease, yes? So there could be a left superior vena cava, a right superior vena cava. There could be juxtaposition of the right atrial and left atrial appendages. There can be total anomalous pulmonary venous return. There could be a direct entry of the hepatic veins into the right atrium. All of these things have to be taken into consideration when one is performing an operation to convert no conduction into slow conduction into no conduction. This is an area that when one does it in the left atrium, the so-called maze procedure for the left atrium, we isolate the pulmonary veins like this and put some other lesions like that, and this is what it looks like in a cartoon. This is in the left atrium, not in the right atrium. And so you can do this by cutting it or by freezing it. Here you have both cutting and freezing, and this works quite well. And in the end, this is what it looks like. Patients with a pacemaker, extracardiac Fontan, and you see the incisions that were made in order to do this operation. I have about 2 minutes, right? Am I finished now? So, sick patients with Fontan, there is hope. We're doing things for them now. New VADs are being developed. Destination may be an option for patients who are very sick with Fontan physiology. Stem cell research could grow a right ventricle or grow part of a right ventricle and valves. And the research, of course, has to start somewhere. It has to be performed carefully and diligently, and in fact, it may take time. So sorry to rush this part of the talk, but I appreciated being here, and thank you for having me.